In our practice, we believe that the first and most important technique is ultrasound. It is a non-invasive technique that does not require injection of radioactive material or needles to be stuck in the patient, and is successful at identifying the abnormal parathyroid gland 85% of the time.
So we're able to look very carefully at the neck, see if there are enlarged parathyroids, and see if there are thyroid lumps that need biopsy. And if that's the case, we can deal with it right there in the office and make a decision about whether surgery is necessary, and if the surgery is necessary, what kind of anesthesia, and how can we minimize that surgery so that the patient has to spend the least amount of time in the hospital.
Historically, the surgery for hyperparathyroidism required that all 4 parathyroid glands be evaluated at the time of surgery. One of the potential complications of this procedure was that the parathyroid glands themselves or the blood supply of those parathyroid glands were injured, and patients could end up postoperatively with the opposite problem, which is called hypoparathyroidism, meaning that their parathyroid glands didn't function well enough to have a normal level of parathyroid hormone. And those patients were actually worse than when they had too high a level of parathyroid hormone in their blood. To prevent that, we perform a minimally invasive procedure in which only one parathyroid gland is examined at the time of surgery and excised. And we can prove that the patient is cured not by examining all 4 parathyroid glands, but by evaluating the parathyroid hormone level in their bloodstream before and after removal of the abnormal parathyroid gland.
It used to be that surgeons would recognize that generally the patient sort of needed a surgical procedure, and they would go in and basically ad-lib it. They make a big incision and they go in, and the surgery is sort of done on the fly. We don't do that here. We know what we're going to do when we enter the neck. And 95% of the time, that's exactly what we end up doing. I think the skill of your surgeon is so important when you do endocrine surgery. It's extremely important to have somebody who does this almost exclusively. Dr. Bimston, for example, does over 400 endocrine surgeries a year. That's a very sizable number, and what it tells you is that his experience level is unparalleled, and that he has the exposure to all different anatomic variants every year. He sees so many different people that he's developed his talent in that area to the point where thyroid problems that might be difficult for other surgeons are commonplace for him. So to have a surgeon who's devoted to endocrine surgery is unique, and that very much fits the memorial care model.